Hello, I'm Hope Rugo from the University of California, San Francisco's Comprehensive Cancer Center, and I'm here with my colleagues at the San Antonio Breast Cancer 2019 meetings to talk about some of the exciting findings that we've heard this year and how they will apply to clinical practice now and in the future. Here with me on the panel is Dr. Aditya Bardia, who's at Mass General Hospital in Boston, Dr. Mark Pegram, who's at Stanford University in California, and Veronique Dieras, who is at Unicancer France, and then Alessandra Gennari, who is at the University of Eastern Piedmont in Italy. So we have representation from all over the world, from Italy, France, and the three of us from the United States, but from different coasts. So you get really a broad perspective on different areas. One of the areas I think that brought about a lot of excitement at San Antonio this year was treating HER2-positive breast cancer, both in the early and late stage settings. And I think that both data sets really probably will impact our practice both today and in the next year, depending on the availability of agents. So let's start actually with the metastatic presentations that we saw. And we saw three different presentations. HER2-CLIMB with a new oral tyrosine kinase inhibitor, tucatinib. We saw data from a new antibody drug conjugate that has brought up a lot of interest, TDXD, or trastuzumab exatecan. And then a novel Fc-engineered HER2-targeted antibody, margetuximab. So Mark, tell us a little bit about the two studies with tucatinib and TDXD and what you got out of those.
Well, both of these trials are potentially practice-changing because the data are so robust that it's anticipated that both of these approaches may win regulatory approval in the not-too-distant future. First, the Catnip data. This was a combination of capecitabine with trastuzumab plus tucatinib versus placebo. And at the first planned interim analysis, interestingly, three critical endpoints were met with statistical confidence, including the primary endpoint of progression-free survival in the intent-to-treat population, overall survival in the intent-to-treat population, and also, interestingly, progression-free survival in the subgroup analysis of patients who had prior history of HER2-positive brain metastasis. So given the fact that all three of those were met with statistical confidence at the first interim, that really speaks to the robust nature of the data. And consequently, I think it will probably win regulatory approval and be available for consideration for patients. I think a unique attribute of tucatinib is its activity in the brain. We saw that from the phase 2 trials prior to this study. And so I think that will probably be preferred in that setting. You know, I think the tolerability is acceptable. Of course, there is some GI toxicity when you combine a HER2 kinase inhibitor along with capecitabine, and so we must be mindful of that particular issue, and also, of course, PPE from the capecitabine. But overall, that was a very impressive data set, in my opinion, published in New England Journal on the same day, and I think will likely win regulatory approval and be available for consideration in patients following TDM1. The other interesting thing about that trial is how heavily pretreated the patient population was. They had prior pertuzumab, trastuzumab, and TDM1, and so to see an efficacy signal in such a heavily pretreated group is quite impressive. The second trial that could potentially be practice-changing is with DS-8201. This is an antibody-drug conjugate with a HER2 antibody conjugated with a cleavable linker to a topoisomerase I inhibitor payload. This drug had very robust activity in early clinical development, including a high response rate even in the phase 1 dose escalation. And so what we saw at this meeting was a very, very impressive result with the waterfall plot showing a 61% response rate. Which is unprecedented, again, in a very heavily pretreated population after TDM1. The caveat about that data is that there is some toxicity that is of particular concern, and that's the interstitial lung disease, including, including about 4 cases that were grade 5, unfortunately. And so now, in the development of that particular antibody-drug conjugate, all of the ongoing protocols have introduced a very intense campaign to screen and identify and intervene early for any patients who develop interstitial lung disease while on treatment. So if that barrier can be overcome, the efficacy signal is so unprecedented and so robust that this could also be potentially practice changing. This sets up a quandary with what to do in patients who are progressing on TDM1, which approach to use, the TKI approach or the new antibody drug conjugate. For my personal feeling, I think that it's going to be a balanced discussion with patients to talk about the pros and cons of each approach. The tucatinib approach already has a proven overall survival benefit, while the DS-8201 data doesn't yet have that, but probably will at some point in the future. And then, of course, the safety profiles are unique to each approach. And I think explaining the various pros and cons to patients could allow them to be engaged and help make that decision. At the end of the day, our patients with HER2-positive disease are doing so well for so long that even after TDM1, many times we have patients that are still ECOG 0 with normal laboratory parameters. And so consequently, it's likely that many patients will probably get both approaches at the end of the day, in which case the order in which you use them may not make that much difference in the grand scheme of things. We'll have to wait and see.
So, Veronique, I mean, it's really very interesting data. How do you see this playing out in terms of order of treatments and in your patients?
I think Mark pointed very well the data we have. We have one phase 3 trial with overall survival benefit, and the other one is a phase 2 trial. But in this phase 2 trial, the results are really impressive. If we are looking to the objective response rate, the duration of response, and the median PFS, and in a heavily pretreated population. And so I think it will be according to the presentation of the patient, and mainly, for instance, the burden of the disease, perhaps, because with TDX, the onset of response is very early, less than 2 months. And I will say if the patient is progressive outside the brain, perhaps I will favor the EDCC. And mainly, we have a lot of data with tucatinib in brain mets. In case of brain mets, I will favor tucatinib. But again, we don't have a comparison. We have a very good drug, and it was a very great news in this symposium to have new treatment option for this HER2 positive metastatic breast cancer. So we are very confident for the future.
Yeah, it's interesting. I think figuring out the toxicity in real-world populations is going to be very important. You mentioned the ILD. Diarrhea rate with tucatinib is the lowest, I think, of any of our oral TKIs.
That's right.
Have less actually effect on EGFR. With a 13% grade 3 diarrhea rate, that's something we can generally manage as opposed to 25% with prophylactic loperamide. But I think it will remain to be seen how this works in the real-world population. So really exciting data, and I expect that these drugs will move fairly rapidly earlier in the course of treatment, particularly because we've moved all the other drugs into the adjuvant setting,
yes.
neoadjuvant setting. But and I presented the data, updated data from the SOPHIA trial with margetuximab, and that drug, which is an FC engineered antibody that has more affinity for the IgG CD16A FC gamma receptor and less activity against the inhibitory CD32B receptor, has shown significant improvement in progression-free survival in heavily pretreated HER2-positive breast cancer when compared to trastuzumab when both are combined with chemotherapy. But although the p-value was very, very good, the absolute difference was relatively small in progression-free survival, and the overall survival data is still a little bit early and shows a non-significant trend. I think where the real interest is in this agent, and I think we're going to need more data, is whether or not it has more effectiveness in the patient population who have more of the low affinity CD16A allele, where we've seen a suggestion of an overall survival benefit, although it's not yet significant. The absolute difference was 4.3 months, which is certainly suggestive of a potential benefit. I think we probably all agree that it's a little bit early and we need to see more data in potentially the F population. There's a planned neoadjuvant trial. I don't know, Alessandra, if you had any other thoughts on that.
No, I think that we actually need to to fix the position of each of these drugs in the management of HER2-positive disease, since we are also moving some of these drugs into the adjuvant setting. Okay, so the fact is that with all these new agents, we actually need to understand where to position each of these drugs in the management of HER2-positive metastatic breast cancer. We have now actually evidence from the deruxtecan, from the tucatinib, and also from the margetuximab trial. And these three drugs needs to be sooner or later placed into the everyday clinical management of these metastatic breast cancer patients. So we have to understand if there are niche of patients that require one drugs rather than the other one. For instance, those patients with central nervous system metastasis that achieved a very good response with tucatinib, for instance, or also other the HER2 low metastatic breast cancer patients that still need to be defined, and there are clinical trials ongoing trying to understand whether the deruxtecan is better than chemotherapy, because the actual treatment of this patient population that is now considered HER2 negative is chemotherapy. So I think we have also to wait more mature results from these trials from one side, with overall survival data, or phase 3 confirmatory trials in the case of the deruxtecan trial. And also we need to wait to figure out the true molecular feature of this patient population.
The other potential path forward for margetuximab, at least based on preclinical data, is combinations with pertuzumab. In the preclinical data, the combination of pertuzumab and margetuximab maintains its enhanced ADCC activity, so the pertuzumab doesn't contaminate that signal in any way. If that holds true in the clinic, then dual antibody combinations could move forward with a margetuximab base replacing the trastuzumab potentially.
Yeah, I think that's really interesting, and of course we're going to see a lot of different combinations with these novel agents as we move forward as well. We saw some very interesting data in the early stage HER2 positive setting as well, with both TDM1 and then an update on affinity. Maybe you could tell us a little bit about the TDM1 attempt trial, DTF.
TDM attempt trial was a clinical trial for patients with early stage HER2 positive breast cancer, predominantly stage 1. Essentially, it was a follow-up trial to the previous APT trial, which was Taxol plus Herceptin single-arm trial for patients with stage 1, stage 2 breast cancer. And the idea was, can we de-escalate the anti-HER2 therapy in the adjuvant setting for patients with early breast cancer? Before that trial, the standard anti-HER2 regimen combination therapy was TCHP or ACTHP. I should say actually ACTH and TCH, because pertuzumab was not FDA approved at that time. And the idea was patients with smaller tumors, can you de-escalate the chemo portion but continue the anti-HER2 portion? So that clinical trial looked at 12 weeks of Taxol and Herceptin for 1 year and showed a very impressive disease-free survival of more than 98%, suggesting that in patients with small HER2 positive tumors, you could de-escalate the chemo portion while continuing the anti-HER2 therapy for a year. Now, that trial didn't look at a question of 6 months versus 12 months of anti-HER2 therapy, and that's an open question at this time, whether we can even de-escalate the anti-HER2 portion for patients with small HER2 positive tumors. So this clinical trial, the attempt trial, looked at the question of comparing TDM1 to Taxol Herceptin. Can we even get rid of the chemo portion and essentially use the antibody drug conjugate TDM1 as the chemo portion, if you will, for HER2 positive tumors, and essentially demonstrated that there was no major difference in the disease-free survival between adjuvant TDM1 and Taxol Herceptin. We still need additional follow-up, but at this time, from a disease-free survival perspective, the outcomes look similar. In terms of quality of life with TDM1, the quality of life did appear to be better as compared to Taxol Herceptin, but the trial didn't meet its primary pre-specified endpoint of the threshold that they were interested in as far as patient-related outcomes are concerned. I think personally TDM1 is a reasonable regimen to consider in this setting, but because the trial didn't meet its primary endpoint, it's unclear whether from a usage perspective, physicians would feel comfortable using TDM1. The other thing to consider is that for stage 2, stage 3 HER2-positive cancers, we're already using neoadjuvant anti-HER2 therapy, and there's an increase in the use of neoadjuvant therapy for HER2-positive tumors because based on the response to neoadjuvant therapy, we can select adjuvant therapy. If patients don't have a PCR to the neoadjuvant regimen, you can use adjuvant TDM1. And so I think with the increasing use of neoadjuvant therapy, the usage of adjuvant therapy has decreased, and this question of what should be the optimal regimen, the optimal adjuvant regimen is predominantly for patients with 0.5 or 1 centimeter HER2-positive disease. For tumors that are larger, we would be using neoadjuvant chemotherapy.
Yeah, I think it was a really interesting trial, 3-to-1 randomization. So you have a lot more patients in the TDM1 than in the trastuzumab and paclitaxel arm. I think when we first started using APT regimen, we thought it was very easy to use, and I still do think it is. But there are differences in terms of alopecia and neuropathy that favored the TDM1. But a lot more patients dropped out of the TDM1 arm in the last 6 months of treatment. And of course, you wonder whether or not you really need a year of treatment. Maybe you could have 3 or 6 months where we know that there's some efficacy. So I think it is fascinating. There were some comments that there might be specific patients you would use this regimen for. It's not approved, and I think the cost is certainly much higher. I don't know, Veronique, what your thoughts are.
I think it was of interest if we look to the toxicity profile, but my first comment was the duration of TDM1, because we see that many patients drop the TDM1 before 1 year. 6 months may be sufficient. Of course, it's of interest for some, I would say for some patients, and perhaps elderly patients, because sometimes we face small neuropathy with paclitaxel. So this may be an option, but in France, at least, we won't be allowed to give TDM1 with this data. So it's not approved. We have TDM1 after neoadjuvant therapy in patients we didn't experience a PCR, but not in the adjuvant setting. I can't see in the next future to have this drug approved with this data in France, as it's not.
I think that's probably right, and hopefully there'll be a study where we can look at shorter durations and see if maybe that is an alternative over time. We also saw an update of the Affinity trial with adding pertuzumab to trastuzumab in the adjuvant setting. I think we all got very much used to giving it as neoadjuvant therapy, and the Affinity trial, when it originally had presented data with a little less than 4 years of follow-up, had less than what we would say a striking difference in disease-free survival, and I think we were all kind of in some ways surprised that it didn't show more, but thinking that it probably was because there was a lower risk population in general in Affinity and the adjuvant setting, and then they added on the more node-positive patients in the last 10 months of the study. So we were sort of looking forward to what we saw today. There was a suggestion that there was an improvement in node-positive disease even in that early data set. What did you think of the updated data from Affinity?
Well, I think that actually this updated data from the Affinity, they confirm the fact that pertuzumab is a drug that must be used in the adjuvant treatment of early breast cancer, either in the neoadjuvant setting or in the adjuvant setting, but as you told, the adjuvant setting now in HER2-positive disease is limited to the very small tumor, to T1 tumors, because otherwise we know that we must do neoadjuvant chemo to favor the prognosis of our patients as a chemosensitivity test. But nevertheless, we have finally data that should convince local administrations to reimburse pertuzumab, because maybe you do not know, but EMA actually approved pertuzumab with the Affinity data, with the first Affinity data, like you did for FDA, but at the different country level, pertuzumab is not reimbursed in Italy. So pertuzumab is not reimbursed in Italy, in France, in Spain, and also in Germany. So we cannot use pertuzumab in the adjuvant setting or in the neoadjuvant setting. That's the problem in Europe. So you can use pertuzumab, but we cannot. So if you have a 30 years old girl with 4 positive lymph nodes and 1.5 centimeter tumor, let's say that you want to use that because she got surgery in any case, adjuvant pertuzumab, we cannot. So we hope that this new data will convince our administration to change the approval conditions of pertuzumab and to allow pertuzumab at least in a part of patients.
For
Because
no
we cannot
positive
use
disease, yeah.
not positive, younger age or whatever, but that we can at least use in some patients.
I
That's the
think
problem.
the data was quite striking for
Yeah.
positive disease now with the better disease-free survival, but it's interesting, there's no survival difference.
No, it's
No.
too early.
So, well,
Hardly any events, really.
we wonder, with all these additional treatments that we have available and the duration of survival in the
It's true, too.
metastatic setting, it may actually be quite an elusive endpoint, which may
agree.
affect, again, reimbursement outside of the U.S. But now the difference between ER positive and negative has gone. So one of the questions
That's
that
an
came up
important
was-
point. We should emphasize that,
It
that
is.
it's very clear now with longer follow-up that ER-positive patients benefit as well as ER-negative patients in affinity.
And this is the node-positive group of higher risk disease. There was no benefit in node-negative
Correct.
disease. So one of the questions that comes up, Mark, if you treated a patient who had clinically node-negative disease in the neoadjuvant setting, since we are really focused in neoadjuvant treatment to try and alter the outcome by altering post-neoadjuvant therapy based on
Right.
the TDM1 Catherine data. If you have a patient with clinically node-negative disease, will you continue PCR? Will you continue the pertuzumab for a year?
I generally do because, the general principle of oncology is, we struggle so much in solid tumors to achieve, pathologic complete responses in the first place. So if something's working that well, I'm as motivated or perhaps more motivated to continue a highly effective drug. There is an opportunity for de-escalation, but in the absence of data, I think it's a little bit risky. We don't know with certainty whether stopping pertuzumab just because you've attained a PCR will be as effective. And I'm really concerned about long-term follow-up. If you look at all of the original pivotal trastuzumab clinical trials in the adjuvant setting, HERA, BCRG-006, the joint analysis, all of those now with 10-year follow-up have more than a 25% relapse risk. So we've converted HER2-positive disease from an aggressive disease with early relapse events to a more indolent disease akin to steroid receptor-positive disease indeed, with these late events. And I'm very concerned whether we might find that by dropping effective therapies too soon, we might see late recurrence risk go up. So in the absence of data, I'm inclined to generally stick with any regimen that helps me achieve a PCR.
I think that, it's an interesting question. Now there's about 6 years of follow-up for, a little over 6 years of follow-up for affinity. And with the impact in both node, ER negative, ER positive disease, but all node positive, which is what those trastuzumab studies were, where there was the continued relapse. So maybe what we're doing is impacting that relapse, although we didn't impact CNS relapse. So it brings up the point of whether an oral TKI might impact that area. So it certainly is an exciting area in HER2-positive disease. We've made a little progress in triple-negative disease with immunotherapy. We saw an update from the neoadjuvant Keynote 522 trial at San Antonio this year. What did you get out of the update? It was updated from the original ESMO presentation.
Yeah, so in fact, the update confirmed what we have seen during the ESMO, is the addition of pembrolizumab to a backbone of chemotherapy, a good backbone because it was taxane, carboplatin, anthracycline, cyclophosphamide, increase the rate of PCR in favor of the immunotherapy, and moreover there's I would say a strong trend for EFS in favor of immunotherapy. But what we want to know with the difference in the metastatic setting in the inpatient study where PD-L1 positivity was predictive of a better effect, It was not clearly the case in the neoadjuvant setting, but I think the main predictive factor should be the TILs, but it was not presented. I expected the presentation of according to the TILs about this effect, because of course it's positive, but we know that in triple-negative breast cancer there's a lot of heterogeneity, and even if it's not too toxic, it's not adding another drug in patient in a curative intent, we have clearly to select patients who will benefit from this approach. And I would say that the discussion was very fair after that about the immunotherapy, what we are today. We have, of course, it's positive because triple-negative breast cancer, we need more treatment options. But today, I would say I'm not convinced that immunotherapy should be a standard of care today for the neoadjuvant setting. We have to have more data about the other studies that are ongoing. It's the Italian study from Luca Geni. I don't know if you want, the NeoTrip want to speak, but it's a very different population, a more aggressive disease with more T3, T4, not positive. So I think that clearly it's a good point, but we are at the beginning of the story for immunotherapy in the neoadjuvant setting, in my opinion.
The event-free survival study was powered for event-free survival, but PCR was powered on half of the population, so they've reported 600 patients essentially with this, I think, impressive difference in PCR.
Yeah, yes.
But event-free survival, maybe we'll see some data next year, which I think is really critical. But we saw data from NeoTrip. The keynote trial was with pembrolizumab, NeoTrip with atezolizumab, but there was a different design to NeoTrip. Maybe
There
tell
was
us a
a
little
different
bit.
design and a different patient population, because actually the patient population NeoTrip was actually more locally advanced disease. They had a high percentage of locally advanced disease, and then there was stage 3. Most of the patients were in stage 3. So the disease was more advanced. According to the fact that when the NeoTrip was designed, there were no data on the combination of anthracyclines and atezolizumab. So they decided to do neoadjuvant with carbotaxol, plus or minus atezo, surgery, and then the anthracyclines after. So you did not have the immunogenic cell death induced by anthracyclines before the surgery. A difference with the keynote trial, where all the chemotherapy, including anthracyclines, was given before. So this is maybe one of the most important differences. And also the fact that NeoTrip, the primary endpoint is actually event-free survival and is not PCR rate, but just they reported now preliminary data on PCR rate. But I think that the most important difference is the composition of the adjuvant chemotherapy backbone in these two different trials.
Yeah, it's, I think, really fascinating, and many, I think, discussions have come up about whether or not a young person with locally advanced triple-negative disease should receive an immune checkpoint inhibitor in the neoadjuvant setting. But I really agree with you that I think it's premature. We just don't know, and outside of the setting of a clinical trial, you can have permanent endocrine toxicities, and we have no idea if you're really benefiting. Teacher, would you use a checkpoint inhibitor in the neoadjuvant setting?
Yeah, I think the jury is out at this time till we see an improvement in event-free survival, or at least continuation of the trend. It's very difficult because the whole premise was based on the fact that if you have PCR that is associated with improvement in event-free survival, but that model is well validated for neoadjuvant chemotherapy, we don't know the validity of that surrogacy for neoadjuvant immunotherapy. And so till we get additional data, I think it's tough to use neoadjuvant immunotherapy for everyone. We do know that these agents have adverse events. They can be associated with immunotherapy-related AEs, hypothyroidism, hepatitis, a small but known risk of type 1 diabetes. So I think we have to balance the risk and benefits.
I agree. I mean, in the keynote data, the event-free survival curves are promising. They're starting to separate. However, the bar was very high at this data cut because the pre-specified O'Brien-Fleming p-value had 4 zeros after the decimal. So we're not quite there yet, but maybe over time, as that data matures, we'll finally see an EFS signal. On that occasion, it could become practice-changing.
Yeah, I think people are really looking for that. And the other interesting thing I think about these studies is that the immune checkpoint inhibitors continued after surgery. And so there may be some impact in that longer duration of exposure. We saw overall survival benefit in the Impassion trial that was much greater than the PFS difference. So it will be interesting to see what we see coming out. And of course, our poster discussions at San Antonio, there were so many different combinations with immune agonists and with different antibodies, different chemotherapies, and many biomarker studies, which haven't really brought us a whole lot closer yet. But it is an exciting field that's moving ahead quickly, and we'll see what happens. But you routinely test for PD-L1 in your metastatic triple-negative population?
Of course.
And would give tezolizumab with nab-paclitaxel?
No
new standard care?
nab-paclitaxel in France because it's not
So you give
reimbursed,
paclitaxel?
but we use with paclitaxel. We have an open access to atezolizumab with paclitaxel today in France in PD-L1 positive triple-negative metastatic breast cancer.
And similar in Italy?
In Italy, yes, we use with nab-paclitaxel, but we are not yet allowed to use it. It's not approved by our regulatory agency. It will be a matter of time.
And you can use for PD-L1 positive is the SP142 assay.
Yeah.
Right.
So, there's been a lot of interesting discussions about the assay,
Yeah.
the studies that we've been doing with it, but so far still SB142 seems to have the best correlation with response, and so.
We need an
additional
ASCO CAP
studies.
committee
Yeah.
for
Yeah,
PD-L1.
exactly.
Similar to ER and HER2, I'm sure that's where the field is headed. Probably.
Yes, I think so, because the assays really measure something different, and they don't really completely overlap at all, so it'll be interesting to see what comes out with more studies and looking forward, particularly because it didn't make any difference in the neoadjuvant trial.
Exactly, no difference in the neoadjuvant trial.
That was
whether
interesting.
PD-L1 positive or not, although it's using a different assay. Yeah, it is quite interesting. One of the biggest areas we treat in early and late stage breast cancer is hormone receptor positive disease, and we saw a bunch of different studies on hormone receptor positive disease at this meeting. After the survival benefits that we've seen at ASCO and ESMO, I think they still have an impact on our thinking, the new data that we saw. The NSABP provided a longer follow-up now with almost 10 years of follow-up for their extended adjuvant AI trial, which I think was very, very interesting. How do you incorporate that data now into your practice?
So I consider the extension of endocrine therapy to my patient mainly in not positive patient and high-risk patient. There's data about the predictive value of the endopredict signature about risk of late relapse. But we have not all this signature for all the patients. But mainly after 5 years of AI, it's a discussion between the physician and patient, considering the tolerance profile for the patient. But usually in my practice, in patients with high risk of recurrence, mainly not positive disease, they agree to at least to continue endocrine therapy. But we don't know today, and we have the Austrian study with only 7 years of endocrine therapy, showing that it may be sufficient than 10 years. So I would say don't know. Yes, for not positive high risk, I will propose to continue endocrine therapy, but for how long? Still a debate.
The difficult decision, too, is colored by the added toxicity of additional 5 years of AI.
Yes.
It's clear from studies even prior to B42 that with another 5 years, the fracture risk continues to go up, the osteoporosis risk continues to go up. And so ideally, it would be nice to have a biomarker that could identify the patients who most benefit from extended adjuvant endocrine therapy. To that end, at this San Antonio, there was an update on the Trans-ATOM trial, which was 10 years of tamoxifen versus 5. So it wasn't AI, but it was still extended adjuvant endocrine therapy. And the database has been updated now this year to more than 700 patients. The original report from ASCO was 583 patients. And the data appear to be holding up. These patients with a high HOXB13 to interleukin-17B receptor ratio, the so-called breast cancer index, if that's high, there's a clear statistically significant benefit for extended adjuvant endocrine therapy with a hazard ratio of about 0.35. And so this confirms prior observations with the same assay in a study from Stockholm and also MA17. All three of those studies had similar hazard ratios of about 0.35 in favor of extended adjuvant endocrine therapy for the H to I ratio high subgroup. So maybe there's some promise that we can, hone in on just the patients who need it and not unnecessarily expose patients to additional risk by continuing longer. If we could exclude those patients, and that would reduce risk in the general population.
Yeah, I hope that the NSABP population where they collected tumor will be a really great area to study these tests, and to predict the biotheranostics tests.
At last San Antonio as well, Christina Curtis had data on some of the INCLUST classifiers as being associated with late relapse, so perhaps those would be useful as well.
Yeah.
We'll see.
Also, we saw some about this clinical score, scoring system, and whether or not that might predict late recurrence. I don't think we're generally using it. I don't know if you have
No,
any
we're
particular
not.
thought about that.
It seems too simple to be used, actually. That's the problem. It's too simple. You say, what about 5 questions?
Yes.
It seems too simple. I say, I can make it without it.
Right. You can guess.
So, no, the important thing in the duration of adjuvant endocrine therapy is to clearly identify those patients who really require this. And this is not, in my opinion, based on the clinical risk, because in the NSABP 42 trials, we also, by multivariate analysis, that the inferior T was benefiting from extended adjuvant therapy. Inferior. Smaller tumors had the biggest benefit.
Yeah.
With no difference between a node positive and node negative. And we should also consider this data in the light of the updated data from the ABCTCG that were presented that clearly show that the risk of late relapse for those patients diagnosed after 2000 is lower. These are projected data, of course, but the risk is lower than for patients diagnosed before 2000 because of better diagnostic tools, more aggressive treatment, better treatment and whatever. So we should also take into account that the patients that we face today have a lower risk of late relapse. So the possibility to identify with a biological test, whatever, those patients who are going to have a late relapse is mandatory today, in my opinion. Actually, it's one of the unmet needs that we have.
It's a big unmet need.
Yeah.
I agree. And in general, do you extend adjuvant endocrine therapy?
We do consider extended adjuvant therapy, and we are believers in the BCI assay. At least over the past few years, we've been using the assay, and it appears to work very well because I think the advantage is it provides 2 pieces of information. The first is the risk of relapse. So you can identify the subgroup of patient population that is at higher risk of relapse. And the second, it also provides whether the patient would respond to extended adjuvant endocrine therapy. So it's both the components which I think is very valuable that this assay provides. In terms of workflow, we usually send this assay at the 4th year of endocrine therapy. We know that this is a patient who's tolerated the adjuvant endocrine therapy well and potentially would be a candidate for extended adjuvant therapy. So that's the time we send the assay, and when the patient comes back for the 5th year of follow-up, you have the results, and then you can discuss with the patient.
So we also saw some really interesting data about choice of treatment in terms of chemotherapy or endocrine therapy. The PEARL trial looked at postmenopausal women and randomized them to receive either endocrine therapy with a CDK4/6 inhibitor or chemotherapy with capecitabine. Of note, the first half of the trial, patients received exemestane, and then because of concern about ESR1 mutations, the second half of the trial received fulvestrant. They had some interesting results, Alessandra.
Yeah, these results are potentially not practice-changing, but they are maybe ameliorating the way we treat ER-positive metastatic breast cancer. Because in this patient population, that was heavily pretreated. It was more heavily pretreated than the patients enrolled in the registration Paloma 3 trial. So these patients were randomized to the combination of Palbo and endocrine therapy. Initially, this was exemestane. Then, due to the fact of, as you said, ESR1 mutation, they moved to fulvestrant. So among the 300 patients, we have more or less 150 half treated with exemestane, and the remaining half treated with fulvestrant. So the results are mixed, in my opinion, are confused by this, because the primary endpoint was to evaluate if the combination of palbo and fulvestrant was better than capecitabine. So actually, the trial failed to show that the combination of palbo and fulvestrant is better than capecitabine in this heavily pretreated patient population, even according or by ESR1 status or by any other analysis that they could do. So the question is it the true positioning of CDK4/6 inhibitor? And the answer now is clearly no. We must use these drugs early in the metastatic history of a patient. So hopefully first-line treatment, as of now, taking into account the available drugs that we have now, maybe the first-line treatment should include the CDK4/6, because it's the best way to position this drug. And afterwards, they will receive chemo after all the endocrine pathway have been explored, in my opinion. So the other feature is that actually in this patient, capecitabine performed very well, because with a median progression-free survival of 10 months in a patient population that was, in any case, heavily pretreated with prior chemotherapy also. So it was not first-line chemotherapy for all the patients. It was second-line chemotherapy, at least in 60% of the patients. So, I mean, 10 months is very, very huge data. On the other side, the combination of palbo and the fulvestrant performed not so well in this study. So, in any case, I think that a true message from this trial is that we must use these drugs early in the treatment of metastatic breast cancer.
Yeah, I think it's just fascinating to see how much we're learning about how prior chemotherapy reduces the value of endocrine treatment afterwards, and sort of generate global resistance. And I think that's really what I got out of the PEARL trial. Also, we had seen the young PEARL where there was less heavily pretreated premenopausal population from Korea, where it was an investigator-initiated trial. This was a larger trial where it appeared that the endocrine therapy plus the CDK4/6 inhibitor was better than capecitabine. So I think there's a lot of issues with line of therapy and what treatment you're giving to what population of patients.
What really concerns me is current market research data in the U.S. showing that first-line metastatic ER-positive HER2-negative breast cancer patients still frequently get chemotherapy first, even in the CDK inhibitor era. It's really striking. People say that, patients with visceral crisis should get chemo first, but the numbers are way more than the percentage of patients that are in trouble that we actually see, which is low single digit, well under 5%. And yet we're seeing 20%, 25% first-line chemo still. And this is a great concern, because this data shows that these post-chemo patients really don't seem to have the same efficacy signal with the CDK inhibitor. I worry a lot about that, and I think it's an opportunity to hopefully make practitioners aware that first-line CDK inhibition is associated with a 55% response rate in all 3 of the pivotal trials with AIs, which is much higher than chemotherapy even in ER-positive first-line metastatic disease.
And I think the fact that we saw such big survival differences in patients who were naive to chemo versus a much more narrow survival difference in patients who've received chemotherapy in the registration trials is also very interesting. There's also the question of what we do with patients in the neoadjuvant setting who have ER-positive, relatively larger tumors, and whether chemotherapy is a better approach than using an endocrine therapy CDK4/6 inhibitor. The Coraline trial looked at ribociclib, published on the day it was presented. Any thoughts on that data? I don't know if anybody's particularly interested in talking about Coraline and making a comment in detail.
So essentially, the trials showed that there was no difference as far as response is concerned between chemotherapy and endocrine therapy plus ribociclib, and the study did interesting analysis looking at PAM50 and how the PAM50 would change with the use of chemotherapy and endocrine therapy, which I think from a biology perspective is very interesting. But from a clinical perspective, the study essentially showed that there was no difference. And you can argue it either ways. One would anticipate that given the impressive results of CDK4/6 inhibitors in the metastatic setting, and as it was discussed earlier, at least in the first line setting, which would reflect what we see in the neoadjuvant setting, we should see an improvement in the response rate with endocrine plus CDK4/6 inhibitor as compared to chemotherapy. But in the metastatic setting, we tend to use single agent chemotherapy, and in this setting, it was combination chemotherapy. So it's not really fair comparison between first line metastatic and neoadjuvant regimen. To me, it just gives comfort that for a patient who is not a good chemotherapy candidate, maybe we can have another option, and that would be endocrine therapy plus a CDK4/6 inhibitor.
I thought it was interesting because the patients selected for Correlline were by PAM50 or intrinsic subtyping luminal B type patients.
Were high risk.
Yeah, they were a luminal A at the end, which is kind of funny. I mean, you see these people have low Ki-67s after getting neoadjuvant whatever, and they still have lots of cancer left. So clearly we're doing something which may be temporary in terms of what we're seeing in the tumor biology. But do you use neoadjuvant endocrine therapy in your patients?
So, in fact, the Correlline trial, we performed the NEOPAL trial in France, exactly the same design, comparing chemotherapy with anthracycline-based, taxane-based, versus palbo-letrozole in the neoadjuvant setting, and no differences in the response. And we are looking to extend follow-up about the EFS, because it thinks as a population, and we think, of course, to elderly patients, we don't want to give some chemotherapy, that this may be a good opportunity. So today, in France, yes, I use neoadjuvant endocrine therapy in some patients, but mainly, I would say, elderly patients, not candidate to chemotherapy. With low proliferative index, and in order to see if we may have a conservative treatment after. But I think with endocrine therapy, we have to look more than 6 months of neoadjuvant treatment. I think to wait perhaps 8 months to have the maximum benefit, and then
but also event-free survival. These trials, none of them are powered on event-free survival, and it's really the key endpoint in the long run. There are, I mean, certainly you have given neoadjuvant endocrine therapy with ovarian suppression to premenopausal women who have grade 1, extremely slow-growing large tumors. I think it's an interesting question we don't have a lot of data on. I don't know if you've ever done that, or would you use a CDK4/6 inhibitor outside of a trial now?
Outside of a trial, no, not yet, not in the neoadjuvant setting, especially not for a young patient with curative intent. Yeah. But for the elderly, endocrine therapy, is a fantastic opportunity, and it's not used enough in this country compared to in Europe. I think neoadjuvant endocrine is exploited to a much greater degree. But for elderly patients, it's a fantastic treatment. I have one recent patient who refused surgery, and it's been like years ago, and she's just been on a single agent AI, and she won't take surgery, and the tumor is no longer palpable, and she's doing fine. So it can really be impactful, especially with patients with comorbidities or any contraindication to chemo.
What about premenopausal women who come up with these grade 1, big cancers? And
we don't have enough data. Young patient.
Do you give them chemo? Because they're not going to do anything to their cancer.
So,
one of the most important questions is why we don't give chemo plus endocrine therapy in these patients.
That's still an area of exploration.
That is still an area, because we're talking about CDK4/6. CDK4/6 are a sort of chemotherapy, because actually they act on cyclins.
Yes.
It's the same of topoisomerase or something like that. The only fact is that this pathway is active in the endocrine sensitive disease. That's why it's a target therapy rather than a general chemotherapy. So I think we are too much afraid of giving chemo in this period, in my opinion, because we try to select alternative regimens, such as the administration of CDK4/6 and endocrine therapy into the neoadjuvant setting in luminal B disease. So the median Ki-67 in the trial was in the range of 30%. So these are patients that we treat with chemotherapy. Actually,
it's interesting because PCR rates were so low, even though they
Yes,
selected
exactly.
luminal B. Certainly for luminal A patients, even the premenopausal patients, we've given ovarian suppression and endocrine
Yeah.
therapy preoperatively. And I think sometimes looking at Ki-67 change and extent of residual disease, it can help us decide about use of chemotherapy and even in the post-adjuvant, post-surgical setting. So I understand there's not a lot of data, but I think sometimes there are patients for whom chemotherapy is not the
It's
right
not,
Sure.
it will not
regimen.
work, you
I mean, the
know.
clinical
Go right
goal
to
is
surgery.
to facilitate, the operative procedure. So if you get a good response and either convert non-operable to operable or convert, breast conserving surgery
Exactly.
from mastectomy, that's the real goal. And so you can achieve that clinically with a tumor
Yeah.
response with endocrine therapy, even in young patients potentially.
It's really an interesting area, and I think we learned something from this meeting about endocrine therapy in both the metastatic and early stage setting and chemotherapy, but we still have a ways to go, I think, in figuring it out in the neoadjuvant setting. We've talked about some really interesting areas, and of course there were even more that I think are still emerging and not quite ready for clinical use that we talked about and discussed at San Antonio. But there was one drug which may have regulatory approval, an oral paclitaxel that's given with a P-glycoprotein inhibitor called Ensequitur. We won't talk about this study so much in detail. It was this oral paclitaxel given with the P-glycoprotein inhibitor together, which has a lot of fasting involved, which hopefully will be fixed with ongoing studies where it seems like you don't need to fast quite as long. Very difficult for patients with metastatic disease. But it was compared to every 3-week paclitaxel in the metastatic setting in Central and South America. So the question is, if there's a number of other oral taxanes of various types being studied in various ways. Is this an unmet need, needing more oral agents in the metastatic setting?
I think the patients are willing to have oral drugs. It's easier than to go to the hospital to have IV infusion. But this oral drug should be active and very well tolerated. So the tolerance profile of this drug was good, but I was not convinced at all by the design of the study, the fact that they amended and looked to the modified ITT population. And so I'm not comfortable with the result. But we have to acknowledge that this drug look very well tolerated with considering alopecia and neuropathy. So I would like to see more data about this study, and moreover we have other oral taxane we have the Contessa trial with the tezetaxel, comparing tezetaxel plus CAPE versus capecitabine. We have all this thing, but of course, oral paclitaxel, it will be great because we use weekly paclitaxel, so it's a burden for the patient to come every week at the hospital.
I mean, it's particularly exciting if it has an improved safety profile, especially the neuropathy endpoint.
Yeah.
That is remarkable.
Yeah, we're always running into problems where the patients are responding, particularly with ER-positive disease, and then you get out to months and you just can't get the drug anymore because people have so much
exactly.
So it will be interesting to see where this field goes and the further analysis and updated work with this particular drug, which is kind of a unique combination, as well as tezetaxel, and there's another oral taxane from Korea, liporaxel, that's being studied as well. So it's really interesting. Well, it's been great to talk to everybody today. I don't know if you have any closing remarks or just a quick summary of your sort of big thoughts, one sentence as we
When we go back on Monday, what we would do, I think the exciting thing to me is that we have at least 2 practice-changing studies that were presented at San Antonio. With DS-8201 and tucatinib, both of which hopefully will lead to approval of 2 novel agents for patients with HER2-positive metastatic breast cancer. So I think it was a great San Antonio.
I agree. I mean, as San Antonio symposia go, some years are more lean than others. This was one of the better years for sure in terms of things that will actually change how we treat patients, and it'll be to the benefit of our patients. And so I thought it was just a great meeting this year.
Totally agree. Since TDM1 is a major improvement for HER2-positive metastatic breast cancer. So I totally agree with you. The main data are HER2 climb on the derivative.
Yes, I agree. This was one of the best San Antonio for practice changing data, because starting from Monday, you know that you must administer CDK4/6 upfront in the treatment of metastatic breast cancer. This was the most important results, in my opinion, because all the other drugs, we have to see approval or whatever, event-free survival data. But Monday, when I see a metastatic breast cancer patients, I give upfront one of the three CDK4/6 inhibitors, actually one of the two, because as of now I can only use Palbo or Ribo, but in any case it's okay, because Pearl actually was a changing, practice changing.
It's interesting. I agree. I think there's been really a lot of excitement this year because of the clinical applicability. And it was also nice to see that we're making some advances in understanding resistance mechanisms to hormone therapy and CDK4/6 inhibitors, although it appears to be all over the map, and how we're going to apply those clinically remains to be seen. And then some early work trying to look at matching different genetic mutations that are acquired in the tumor with treatment, although I think we're still very much in the beginning of that whole area. It's been great to have you all here today, our international panel, talk about these interesting areas. We really appreciate your thoughts and expertise and wish you safe travels.
Thank you.
Thank you.